Yeah, and they don't want to hear all about me either. So.
Thank you, everybody, for joining us.
Give everybody until 1, and then we'll start things up. Okay, I show 1 o'clock, so hoping that means it shows for everybody else. Let's get things underway. Welcome to the 2021 Intermountain Tribal and Rural Opioid Wellness Summit breakout sessions. This session is titled Suicide Prevention in Rural Utah and is presented by Carol Ruddell, Crisis and Suicide Prevention's Program Administrator for the Utah Department of Human Services. I'm your sessions moderator, Pete Caldwell, and I'll be available in the chat box anytime during the presentation. So before we get started, I have a few brief housekeeping reminders. This breakout session, like the other sessions in the summit, is being recorded, and some content may be reproduced or rebroadcasted at a later time. So if for any reason you wish to remain anonymous during this recording, you can take the following actions now, and I'm putting those instructions in the chat box. To make yourself anonymous, you can click the 3 dots in the upper right corner of your participant panel, choose change profile name, and you can edit your name. And then lastly, make sure your video is off by clicking the video icon in the bottom left corner of your screen. If your video is off, there will be a red diagonal line through the icon. If you need assistance with this or anything else, you can message me directly in the chat by opening the drop-down list and typing Pete Caldwell. This will send me a direct message and we can get everything sorted out for you. To ask a question, we're going to be saving all of the questions for the end with this presentation. So we're going to request that you put your questions in the chat box, and we, based on how much time we have left, we'll cover as many as we can get to at the end of the presentation. So now I'd like to introduce our featured guest for this session, Carol Ruddell. Carol is the Administrator of Crisis and Suicide Prevention Programs for the state of Utah. In 2012, she became the Project Director of the ASPIRE, which stands for Achieving Success by Promoting Readiness in Education and Employment, a U.S. Department of Education Promise initiative. Previously, Carol directed Workability Utah, Utah's Medicaid Infrastructure Grant from the U.S. Department of Health and Human Services, Centers for Medicare and Medicaid Services. Carol was a teacher for 22 years, working primarily with deaf and blind students in 3 states. I have the honor of working with Carol, and I just have to say she's wonderful. I'm looking forward to what you have to say. I'll give the time over to you now, Carol.
Thank you so much, Pete. And thank you, Suzanne, as well. This is a great honor to be here today. I'm sure there are things I'm going to tell you that you already know, and I'm sure that in many ways, folks attending rural and tribal communities are going to also know more than I do on these areas. But suicide prevention is something that we take seriously in Utah. And too often, we think of Utah as just this conglomerate along the Wasatch Front. And I had the privilege, as Pete mentioned, when I worked for the Utah Schools for the Deaf and Blind, I traveled the whole state. And some of my most favorite places in the state are not on the Wasatch Front. And I think it's important, one, we have this opportunity at a conference, but I think it's a conversation we have to continue to have, because Utah is so much more than the Wasatch Front, whether that's our rural ranch lands, our more remote lands that are open, like the Bureau of Land Management, things that we have, national parks, state parks. Utah is big, but too often we focus on the Wasatch Front. And that's not where my heart is. My heart is certainly out in the areas that are not as highly populated. So for me, I'm very passionate about services, whether that was educational services when I was a teacher, or whether that's now suicide prevention and crisis services. So today, that's what we're going to focus on. As you know, Utah's pretty big. It's about just under 85,000 square miles. And while it's the 13th largest state by area, it's 30th out of 50 in population. And it is 41st in terms of population density. And we're going to talk a little bit about what that means in terms of suicide prevention and some of our data around suicide deaths. But, you know, with roughly 2/3 of our population focused on the Wasatch Front, and Washington County is growing. I can remember when it was tiny, so it's growing as well. But, you know, where's the other 1/3, and how is the other 1/3 of our state being served? That's a lot of people. That's over 1 million people that aren't on the Wasatch Front or in Washington County. So in terms of being able to think of what does services mean for crisis services, for suicide prevention, that looks different. There's no question it looks different. So what I'd like to do is start with a little bit of data. I kind of don't want to get hung up on the data, but I think the data can inform what we do in our state. So as you can see, and we know, population increases every year. But what happens with the rest of the things that we talk about with population? So when we consider suicide deaths in Utah, you'll notice the orange line is the national US rate of suicide. The line at the top with the darker maroon line is Utah's rate of death by suicide. What's interesting is since this data has been collected all the way back into the 90s, Utah's rate has always been higher than the national average. That said, if you'll look at that last couple of years there, 2017 till now, we've had a downward trend. It's not statistically significant for those of you who like to know those kinds of things, but what it does tell us, maybe we can infer some things. There's, you know, we have no way to know cause or causation or even correlation to the work that we do. But there's a big investment in the state of Utah, not just since 2017. In fact, 2013, 2012, we have a huge investment both at the state level from our legislature. We have investments from our private sector, especially in the most recent 2 years. We also have quite a bit of federal funding that's come in the last few years. Has this made a difference? I guess we'd all like to think so. I mean, money well spent, right? It's our tax dollars. So we do have this slight decrease. I will also say that while this data is 2019, that is actually our most current validated data. Data for death rates and cause of death is shared from the Centers for Disease Control and Prevention. That is only required to be turned into them annually. We're very fortunate in Utah. We have a suicidologist, Dr. Michael Staley, in our office of the medical examiner. He actually can look at this data real time for Utah, but he can't make any comparisons nationally because that data is only collected once a year. Now, the reason I point that out is because every state is not like Utah. We have one office of medical examiner. If I go to other states, I grew up in Kentucky, we have county coroners, and that's like 67 people who only have to report once a year. So data may come in straggling or not. And again, how it's reported. We're fortunate, as I said, here in Utah, the suicide deaths are evaluated by the Office of the Medical Examiner, and we're able to truly know cause of death and means as well. So, so when we think in terms of who is dying by suicide, this is both by age and by sex. I must say that certainly the categorization of male and female does not reflect non-binary, non-gender conforming, transgender, intersex individuals, okay? In Utah, we only have 2 options on a death certificate. It's male and female. So that is the only way the data can be reported. Again, nothing nothing in our minds in terms of accurately reflecting that when we know that there are different identifications by individuals to have as well. But if you'll notice here, males are orange and the females are the maroon. Males are pretty much outnumbering women almost 2 to 1, 3 to 1 sometimes in terms of their suicide deaths. If you'll notice, between ages 35 and 55, that's our highest rate among men. That's a really important thing to recognize. One of the things I often hear is, well, we have so many teen suicides. A couple of factors I think fall into play there, and this is my observation. One, they tend to make the news more, so we hear about them. That's just honest. We hear about them. The second thing is, I'm a 60-year-old woman who has some health problems. The ways that I could die are many. I could have a stroke, a heart attack. I'm diabetic. There's many ways that I could actually die. I have a driver's license. I could be in a car accident. When we think of young people, ages 10 to 16, chances are they aren't dying by heart attack or by stroke. Chances their options, it sounds awful to say options, but the ways by which someone can die when they're younger are much fewer than how we die as older people. So while that is certainly something we need to attend to, and I believe very strongly that we have to have that upstream approach where we're talking with young people, but we also need to be talking with everybody. It is not just a youth challenge. It is not just a middle-aged challenge. As you can see, we also have individuals who are over 65 that are choosing to take their own lives. So in reality, death by suicide in Utah is across the lifespan. It is not solely what we hear in the news, perhaps, or in our neighborhood. It is truly an issue that crosses all ages of the lifespan. Now, I'd like to take a minute and talk a little bit about race and sex, male or female. And I'm just going to give you a second to look at this particular graph. And again, these are not mine. I should have said that. All of these graphs are actually created by Dr. Michael Staley at the Office of the Medical Examiner. Now, if you'll notice, probably the one that stands out for me, perhaps it stands out for you, is our American Indian individuals. The males have the highest rate of all of these. The other thing that stands out to me is while male seems to be high compared to female in all areas of race, except our Asian, Chinese, Japanese, Filipino individuals. Very close on those two. So it makes me think in terms of, are there populations that we need to be thinking about? Not just males, right? But are there specific populations we need to be concerned about? When I look at the American Indian, Native Alaskan numbers, the female line is its highest among all females. So what does this tell us in terms of our need to address suicide prevention, both with our Asian communities, but especially with our American Indian communities? You know, that's pretty telling there in terms of suicide prevention. The other thing I would also say is all of the races that are represented here also have their own cultural piece. Death by suicide may not be, it may be incredibly taboo in certain cultures. It may be somewhat accepted in other cultures. So recognizing that what race people have and their cultural background also makes a huge difference in terms of these types of numbers for our death by suicide rate. Now, this one is probably the most complicated slide I have, and I apologize. I'm trying to getting everything into one slide is a challenge. Typically in the past, we have referred to our geographical areas by population as urban, rural, and frontier. More recently, what I've learned, I think many of us have learned, the frontier, that term carries some really harsh memories of institutionalization, colonialism within our Native American, American Indian population. And in an effort to move away from anything that causes that kind of pain, but still look at our remoteness, this range from highly densely populated to very remote, we are now using the National Center for Health Statistics categories, and they are by county and by population. So if you'll find your county on the left, all 26 counties are there, and you can look and find what category the National Center for Health Statistics uses for your county. So I'll use Washington County as an example. It is small metro. And down here at the bottom, you'll see that is between 250,000 and 1 million people. Did I tell you that county is growing? Wow, okay. But when I go over and I look on the table of what the rate of suicide deaths are, it's not the highest, right? Now look at large central metro, that is only Salt Lake County. And then large fringe metro is only Tooele County. But look at that non-core. Look at that tallest rate there, nearly 29%. That is half of our counties in Utah. It's 13 of our 26 counties. And if you look at them, they are also our most rural counties, our most remote counties. Non-core means there are less than 10,000 people living in that county. So when you think about, I think about northeastern Utah, we've got Duchesne, Daggett, we've got Millard, Rich, Sanpete down the middle, and Emory. You got Grand. Even though Grand has Moab, it still has very small number of permanent residents. Sevier, Paiute, and Wayne in the middle of central, Garfield, Kane, and of course San Juan counties. When I look at this, it concerns me. It concerns me that suicide death rates in those most rural, most remote counties is the highest of all of our counties in the state. That's pretty significant. And also when you consider counties such as San Juan also have Native American reservations, they have Navajo, they have White Mesa Ute, they have Ute Mountain Ute. You look over at, in Western Utah, you have Paiute, you have Ghost Ute, and those are all end up being in the non-core counties as well. There's a great deal of crossover between our rural, most remote, non-core populations, also containing high numbers of individuals who are also members of the Native American tribes. That's pretty telling in terms of where we need to consider some of our outreach in terms of suicide prevention. So now what? That's the data. That's just the numbers. And numbers don't really, it tells us where we need to focus on things, but numbers don't really tell us about the individuals. It says they're in counties of less than 10,000 people, but what does that really tell me about these individuals? And that's on us. You know, we have to understand our communities. I'm going to talk a little bit more about local coalitions, but when we think in terms of what puts someone at risk, well, I would look at that non-core, and I would look at the male numbers of being high, and I would look at the Native American, American Indian numbers being high, and I would say that's a group that's at risk. Those are folks that we need to be concerned about. So I'm sure I'm preaching to the choir when we talk about risk and protective factors. You guys can probably name them better than I can. But when we consider suicide prevention, we consider opioid use, substance use, there are so many shared risk and protective factors. And quite frankly, I could have made several slides that listed all of those. However, I chose just to list a few because I think these are ones that are important for us to attend to. Risk factors, including what we've already discussed in the data, would be things like prior suicide attempt. You know, if someone has had this consideration, they have no hope. They don't see a solution to a problem. They don't see a way out of their pain. If they've attempted suicide in the past, they may well attempt suicide again in the future. Although most don't go on to die by suicide, I will say that. Mood disorders and how moods can change. Over the past year, we've all been challenged with social isolation and disruption of our celebrations, of life and death and major events, and that has affected folks' mood. It affects their anxiety, their frustrations, their depression. All of that is falling into play. Certainly substance use is a factor within, as a risk factor, and certainly access to lethal means. You know, Utah and the western states, and quite frankly in Kentucky where I'm from, lots of guns. Okay, that's fine. Nothing wrong with having guns. It's what is the access to those? What is the access to the prescription medications that I have upstairs in my medicine cabinet? You know, if I can limit access when someone's in a crisis, if all these other things fall into play, then chances are they aren't going to make that decision quickly. That just lost the word, apologize. But they're not going to make a decision if they have access to lethal means as quickly. So, you know, gun locks, locking up your medication, all of those things are important things that would address those kinds of risk factors. Which leads to the protective factors. You know, we have a lot of good information about having gun locks and prescription medications locked up, but probably the single biggest factor that we have in terms of individuals having protective factors to protect them from suicide death, connectedness, relationships with others. I've been doing a lot of QPR training lately, which is a question, persuade, refer. I've been doing it with faith leaders around the state, and just talking about how are you connecting with people. Asking questions, having discussions means I care, I value you. And when someone is at that moment of no hope and such incredible pain, knowing someone cares about them, that they have a purpose in their lives, that's that connectedness. And so we know that it makes the biggest difference across everything, whether that's opioid use or other substance use disorder, or whether it's suicide deaths. Certainly effective behavioral health care is important. There's no question that that's a protective factor. If I have access to getting assistance and getting into therapy or talking to a counselor, or even access to things that are pre-crisis, that's certainly going to help me deal with the issues, deal with my challenges that I'm facing, hopefully reduce my pain. And effective behavioral health care is tough in rural areas. When we consider those 13 counties that are non-core in our state, sometimes there's not even a major hospital in those areas. Sometimes it's just clinics. And are they behavioral health as well as physical health? Certainly that's something I think we need to improve. I'm a huge health parity fan. I believe that health parity is not just mental and physical health. It is also where someone lives and the access to those services. So, but that is a protective factor. It is something if someone can access those services. You know, we're so fortunate in Utah to have a lot of services that aren't necessarily in a building. We have crisis lines, we have warm lines, we have apps, we have so many other services. We have telehealth now in a way that we haven't had in the past. So effective behavioral health care is truly important, and finding ways to balance that and find how we can do it and have it available to everyone is important as well. Contact with caregivers. You know, there's a lot of people around us, whether that's a spouse, a child, whether that's my neighbor, my pastor, my bishop, whoever it is. I have a lot of people around me that can help notice. The more I'm connected with people around me, the more they can notice a change in my own behavior, how I'm talking, or in any way that might indicate that I'm on the edge of choosing to make a choice of suicide. So the more contact we have with caregivers, the more likely that's a protective factor as well. Problem solving, coping strategies are so key. If I have the crisis line phone number in my phone, if I know the Safe UT app is available, if I can think through, I'm having this difficulty, what can I do? Who's going to help me? Where can I go? Being able to talk through those things, and problem solving skills are something we need across our lifespan. Certainly the younger we are, probably the less problem solving skills we have, but the older we get, we've learned and we've coped. But some folks haven't. So, you know, how do we help folks develop those problem solving strategies? How do we help them find ways of dealing with the crisis that they're encountering in their lives? So risk and protective factors, I think that's true for regardless of where you live. I think it's true for regardless of your race or or male or female for that matter, or any of our LGBTQ+. It means I need to be looking for the things that match my beliefs, my culture, my values. And it means I need to be creating that within the community or family in which I live and reducing those risk factors along the way. So I want to talk a little bit about what we're finding is our most distinct high-risk groups and what are some distinct protective factors. Because we know that I can say those middle-aged men, and I can say LGBTQ+ are at higher risk. I can say they're at higher risk, but the interesting thing is there are also protective factors that each of those groups have as well. And it goes back to that idea of that culture piece, that community piece, the values piece. So let's take a look at those for a second. We have a history in our country of prejudice and discrimination, and we know that that has occurred against our communities of color, whether that's Indigenous folks or whether it's Black, Hispanic, all of our prejudice and discrimination. There's a lot of stress resulting for that, and that is a known risk of suicide. But there are also within each of those protective factors of that community. LGBTQ+ people are not at risk because that's how they identify. That's not, they're not at risk because it's their sexual orientation. They're at risk because of how the people around them have treated them. Low levels of acceptance, lack of feeling of belonging into the broader community. That's what makes them at higher risk. But yet we look at those individuals and we say, they also coalesce together. They also come together in support of each other in a way not unlike a cultural community comes together. So it's a matter of building that support within that community based on the values of that community. We have a lot of historical trauma in our country. American Indians, Alaska Natives, Black Americans, sorry. And that does also provide increased risk for mental health conditions. And it continues, whether the experience was residential schools that our American Indian family and friends went to, or whether that was enslavement or Jim Crow laws or redlining. You know, there's a lot of historical trauma around specific groups. But again, these groups also coalesce and find ways within their own communities to overcome suicide, overcome mental health. But it's within the community. It's not because anything the white folks did, right? And I'm one of those, so. Latinx and immigrant populations often experience a great deal of discrimination, reduced access to services. I worked in Texas for 5 years, and I can tell you it was a very different experience than here in Utah. Here in Utah, I find folks or immigrants are so very welcomed. We see opportunities to help folks get set up in apartments and really help them feel a part of our communities. And quite frankly, I didn't see a lot of that when I lived in Texas. And it was unfortunate because that's a huge segment of our population. And how are we helping to reduce the stress that we associate with perhaps the levels are differing of acculturation, but what the dominant culture is looking at in terms of these families that are not of a dominant culture. They come together, obviously. And I think, again, I'm probably sounding like a broken record, but looking and reaching into the communities that have that culture, the same values, that's huge in terms of reaching these populations, particularly in our non-core areas of the state. How a rancher in Daggett County or in Duchesne County lives and works and has family going on and what they do in their community is very different from how someone living in Cedar City in the city, even though it's a small county, right? It's recognizing what is the difference and what can we do within those individual communities. Mentioned men in the middle years. It's been a challenge. You know, Utah may have a low unemployment rate right now, but there certainly was the stress of, am I going to lose my job during the pandemic? Are my hours being reduced? How am I supporting my family? Certainly for both men and women, things such as divorce, childcare falls into play as well. And as we know, men don't often speak up about their emotional feelings and their well-being, and finding a way to do that is a very important piece as well. We're fortunate we have a wonderful video created by Steve Young, yes, the Steve Young, around men just speaking up and having conversations. And how are we opening those conversations, right? Certainly veterans, service members and their families are at greater risk, and that's due obviously to combat, to trauma, PTSD, separation from family for extended periods of time during deployments. There's a lot going on with our service members. And when I first moved to Utah, my gosh, it's been 30 years ago now. When I first moved here, I was always impressed at how many people were in the National Guard. How many people in the rural areas, the more remote areas of the state, were in the National Guard. We have a huge Guard presence in Utah, and those are families that need our support and need our assistance as well. We're fortunate that our National Guard, for example, has a huge behavioral health team, being sure people connect to that or to veterans services, either through the state or the federal VA programs. There's opportunities there, and that veteran status crosses literally every other group I just talked about. So how can we engage folks in a manner that provides that assistance and build those protective factors when they literally cross multiple cultures, multiple value systems? That's an important piece as well. So as I said, even though these particular groups, if you will, I hate to group people, but if we're going to identify them by a group, they do have higher risk, but they also have those unique strengths. And those unique strengths that they bring within that community is exactly what can overcome that historical, institutional discrimination, all of the things that we've talked about. It's really true of how do we reduce those risk factors, but how do we increase those protective factors? How do we help them find ways in which they can grow and learn and be a part of that community in a manner that increases those protective factors, the positive mental health, positive well-being. So local coalitions, this is where this really comes into play. And again, I know many of you are probably members of your local coalitions, but you really can make a difference in the community by joining together, identifying what those needs are. And that's exactly what our substance use coalitions and our suicide prevention coalitions, many times they're the very same coalition, it's exactly what they're doing. So if you are not involved with the local coalitions in your county or your area, I truly encourage you to be a part of that. You bring a voice to that coalition that is incredibly valuable. Finding ways to reach individuals in the community, regardless of their background, or inclusive of their background is probably a way to say it better. That's how we make a difference. So I would encourage you to join your coalition. If you don't know how to find it, if you go to the dsamh.utah.gov website, there's a section under services called Learn About Prevention in Utah. And you'll see right down at the bottom there, the Utah Suicide Prevention Coalition. You can contact your local prevention coordinators, getting involved with the local coalition. And what ends up happening is it pops up with the state of Utah and you can choose your county. When you choose your county, it allows you to see where the services are, what organizations they are, whether it's the local health department, the local mental health authority, but it'll also identify who that prevention coordinator is in that county. So consider, I hope you will all join your local coalitions. I hope you will find a way to be a voice in your community, because truly we can sit at the state and provide direction and support, but in reality, the frontline work, boots on the ground, is in that local community with that local coalition. Just to give you an update, Utah has had a suicide prevention plan since 2012, and every 5 years it's updated. The first one was 13 pages. It primarily focused on those risk and protective factors. The second one was about 30 pages, and again, focused on risk and protective factors. And I will tell you that the one coming out, please don't hate us, it's about 80 pages. But I will tell you that it's not just quantity that's gone up, the quality of that particular plan has really increased. You'll find all sorts of information about the data. In fact, the data slides that I shared, that is taken directly from our new state plan. We also have a great deal of information about coalitions, a great deal of information about the infrastructure in Utah. In the past 5 years, the expansion to public and private partnerships, the businesses contacting us. We had 2 businesses last week, large businesses in the state of Utah, say, we're concerned about the mental health of our employees. We're concerned about substance use. We're concerned about suicide. What can we do? So we have businesses stepping up, local communities. We have faith groups that are stepping up. This is important. And that local coalition can take this plan and be able to design their own that fits your community. The goals and objectives in it, of course, are set up along those protective factors. I don't think any of us would want it to be any different than that, but it does give us an opportunity to truly consider what we have available to us now in our state and our communities, and be able to develop those plans that are local and customized to your communities. Utah also has an LGBTQ+ suicide prevention plan. It is the first in the country. In fact, other states are now crediting us as they develop theirs, which is kind of exciting, but it really is an opportunity to look at this particular community of LGBTQ+ individuals and how do we prevent suicide within that group of individuals. It's really exciting. I think we're going to see more of that kind of work coming forward, certainly from the work groups of the coalition, but it's just a great opportunity. I encourage you to go check out. Unfortunately, the old one is still up as far as our state plan goes. The new one will be released in September, but the LGBTQ+ suicide prevention plan is already posted out there. You're welcome to go see it. It's on the liveonutah.org site. Coming this summer, quite a large group of folks have been working on a Postvention Toolkit. You know, when we think of suicide prevention, intervention, and postvention, we know that strong, effective postvention is suicide prevention. And that happens at the community level. You know, even in the position I'm in at the state, I don't hear about every suicide death that occurs. I hear about some. When there's a need, when a community is stepping up and saying, we need some help, we need some assistance right now. Those are the ones I hear about. But most of them I don't hear about. And the reason is because communities are coming together. This toolkit will actually enable folks to look at it and think in terms of my community. Who are my key partners? Who can step forward in the event of a suicide? How are we going to respond to that? Who's going to talk to the media? You know, all of these pieces. So it's really a toolkit that allows a community to design a postvention plan that hopefully, we don't want it to ever be used, of course, but hopefully when it's needed, everyone is ready. And the teams you can deploy are there to be a part of the healing process within that community. Certainly in smaller communities, one suicide death we know it has a ripple effect. Hundreds of people are impacted. So being prepared with a good postvention plan will really help that. So that's coming out this summer. It's been a couple of years in development. I won't kid you there, but it is certainly something that has been asked for, and we're really looking forward to getting that out very soon. I mentioned a little bit about Live on Utah. Live on Utah is currently in process. It launched, a little over a year ago. It is a public-private partnership between funds allocated by the Utah legislature and then many private partners from Intermountain Healthcare, the Huntsman family, doTERRA, the Church of Jesus Christ of Latter-day Saints, just so many. And if you I guess everybody had to get their taxes done yesterday. But one of the things you have a choice of is contributing to the governor's suicide prevention program. You know, chip in $10 or whatever every year. That's also a part of this program, and it's expanding. We're doing some great opportunities around the state. We've asked local coalitions to, how would you implement a Live On message within your community? And so we're fortunate. Last year we worked with, I believe, 9 different communities. Some were geographical, some were not geographical, some were the Utah Pride Center, Urban Indian Center, Latino Behavioral Health. So again, what define a community, right? It's not always just geographical. So what I love is the mantra here within Live On Utah. It truly is about hope. Together we can get through, reach out, lift up, look ahead, move on. It's that idea of that connectedness, doing it together. Almost all of the photos you see associated with Live On Utah are about that connectedness, right? That initial connection with people to be a part of each other's lives and to value each other. More recently, the billboards, and I'm sorry, they're mostly on the Wasatch Front. The billboards are even more direct. How do you know if your neighbor is feeling depressed? Ask. That's all it says. How do you know if your teenager is thinking of suicide? Ask. It's just that simple. It's about building those relationships. Because at the end of the day, building relationships is the best suicide prevention we have. So there are resources. I mentioned those, and again, they aren't always just on the Wasatch Front. We have the Safe UT app, if you're familiar with that. It's primarily was launched as a school type, education type program where teens, young people can text in, they can call, they can give tips. I'm worried about my friend. They'll get a response. That information then is shared back to the school to hopefully intervene quickly with a child or a youth. Excuse me, we have a Safe UT Frontline, which launched more recently. That actually has 3 components, National Guard being one of them. That is a huge population in our state. And again, has an opportunity for chat and text, but it also, if someone gives a tip, it will go to the National Guard's behavioral health team so that they can respond and hopefully intervene quickly. It also has frontline healthcare workers, as well as frontline first responders. So the teams that answer either Safe UT app have a lot of background and training to truly target those individuals who are texting in. We do have a suicide prevention lifeline. That's a national phone number at 800-273-TALK. I will tell you, you know, we're so used to our cell phones, everybody knowing where I am with GPS, right? That phone line only works on the area code. So I caution people with us moving nowadays and truly and keeping our phone numbers. We don't change them, right? So I caution people, if you want a Utah response, you'll need to call the Utah phone line. And that's in white down here. This is our local number. Anymore, it doesn't matter if it's a toll-free number or not, right? Area code, but the 801-587-3000. If I call the 800 number, it'll be routed based on my area code. And so in that routing, it will arrive in Utah to the same people who answer the 801-587-3000 number. So it's the same people who would be responding, but you'll get if you have an Arizona phone number, area code, you're going to get routed to Arizona. So just be aware of that. It is not geo-specific like we think of 911 as. So, so just know that. But great folks there, again, clinical staff, folks to answer the calls, be a part of that conversation to hopefully reduce a crisis. The Trevor Project Lifeline is a national number that is answered nationally. Not locally, but the folks who work that line are members of our LGBTQ plus community. So they have that lived experience, they have that knowledge, that ability to share. So Trevor Project is a great line to call as well. The My Strength app is something that the Department of Human Services actually pays for individuals in Utah to be a part of. It does have a direct link to the Suicide Prevention Lifeline, but it also gives you an opportunity to input your information. In fact, I just got an email today. It said, Carol, you haven't checked in lately, and it asks you to check in. How are you feeling? It's not a good day. Okay, it's going to offer suggestions for what I'm going to do to help myself through not a good day. It's really a really nice app, and it really is an opportunity to feel empowered to do something about challenges in my life. On a side, it's not a side note, another note, in Utah, we also have mobile crisis outreach teams, MCOT, MCOT. We now have those statewide, although a few of our more remote ones in those non-court counties are just getting up and getting running. But those are, if I call the Suicide Lifeline and I get that Utah person to help, you know, most situations of crisis can be handled on the phone. Most people can talk through with a clinician, with a therapist, with a peer support specialist, and really de-escalate a situation in a way that the great majority of individuals are served best that way. But in some instances, that's not the case. And maybe they need someone to come out. So we have mobile crisis outreach teams. As I said, a few have just started, so they're just getting their feet under them, but give them a minute and they'll be up and running well. But those MCOT teams can send out a clinician along with a peer support specialist to be in person with someone to truly de-escalate a situation. Now, just a note on that, as a part of a conversation with the Lifeline, you're always going to be asked if there's weapons present. Is someone a danger to another person? So the response may include law enforcement, it may not. If the situation is totally safe and there's no need for law enforcement, MCOT may respond alone, but just recognize that sometimes MCOT will respond in conjunction with law enforcement. And the reason is because if someone has a weapon, they're threatening other people, that situation needs to be de-escalated first. That situation needs to be made safe. Although I personally, if an officer showed up when I was in crisis, you know, badge and a gun, I might not react in my best way. So that's one reason why I love our MCOT teams. It really gives an opportunity for the health care, the mental health care workers to be a part of resolving that solution or resolving that situation and finding solutions. We also have the stabilization and mobile response in Utah. Now, those MCOT teams generally respond for anybody over about like 23, 24, right? Because they can go out, they can de-escalate a situation, they can make sure someone's connected to services. But when it's a child or a teenager in a family, sometimes there's a little more required there. And so our SMR, stabilization and mobile response teams, literally work with that family. They'll, again, take it, work with them on a phone call if that's what it takes, but they can also go out just like those MCOT teams can and be a part of helping a family get stabilized, reducing that crisis within that particular situation. So we have that service as well in Utah. Between MCOT and SMR, it's just really a great opportunity. Now I'll be honest with you, SMR isn't everywhere yet, but I think it's coming. And it's going to require a lot of work on all our parts to get that. But the MCOT teams, our local mental health authorities, are truly making a difference in each of their communities and striving to be that response. So I have to say kudos to them because it's difficult. It's a lot of work to have folks on call and ready to act. So we have a FEMA grant at the state, which is our Utah Strong Recovery Project for individuals who are struggling with the effects of COVID. Now, maybe we are getting more back to normal and less distancing and fewer masks, but COVID has really impacted people financially, if their housing, their healthcare, the whole system. So they can call or text this number, speak to therapists, counselors that can help them move forward and find solutions to specific problems. Intermountain launched their emotional health relief hotline almost simultaneous with the pandemic coming up. And that hotline, that is for anyone. Anyone can call that number. And again, just speak to someone, get some solutions, get your concerns addressed, share your frustrations, your need for hope. And that's 10 to 10, 7 days a week. They are rebranding that. So if you see a new name coming in the near future, don't be surprised. So, because it's something we want to continue that's not just associated with COVID, which it's nice to see them doing that. NAMI is around. I'm looking at my time. I'm going to run out here. The American Foundation of Suicide Prevention, 211, local mental health authorities. We also have a warm line. I guess I'd like to point out that if you're just feeling in need of support and it's not a crisis, you can call the warm line. And then I always have to say gun locks are always available, whether it's your local health department, local mental health authority, or even from us at the Division of Substance Abuse and Mental Health. So I'm gonna stop right there. I'm gonna stop sharing my screen and see what questions popped up, Pete.
Thanks, Carol. That was fantastic. A lot of good information and a lot of good resources there. We don't have any questions in the chat box in the moment. If anybody has any questions right now, feel free to put it in.
Okay, and Robin, you are right. I noticed Daggett was missing when I ran through that list, so I will get that added. My apologies. It is in the non-core group, though.
Not seeing any questions come in, and we are right up to the end of time. Oh, please, no worries. The information that you were putting out was wonderful, and thank you for sharing your expertise with us today. And thanks everybody for being here. We appreciate you joining the Suicide Prevention in Rural Utah breakout session, which was brought to you today by the Utah Department of Human Services, Division of Substance Abuse and Mental Health, the Rural Health Association of Utah, Utah State University, the USU Emma Eccles-Jones College of Education and Human Services Department of Kinesiology and Health Sciences, the USU College of Humanities and Social Sciences, USU Extension, and SAMHSA. We would love to see how everybody is participating and practicing and observing the contents of the summit. I'm putting in some hashtags in the chat. If you feel so inclined to post, be sure to include the hashtags so we can all kind of connect in that way. As a reminder, the main room is still available and open for any general summit questions or help getting into your next session. You can re-enter that room through the link that I'm putting in the chat right now. And if you're prompted for a password, the password is opioid. And let's see, lastly, tomorrow our main sessions feature a live episode of the Debunked podcast, a panel discussion focused on mental health, incarceration, and recovery, a special presentation titled Gender Equity Etiquette, the announcement of our Goose Chase scavenger hunt winners, and closing remarks by Utah State University Extension Vice President, Dr. Ken White. Make sure to log into the webinar before 9 a.m. so you don't miss a thing. Thanks everybody for being here today.
Thank you.